All right. Good morning, everyone, or good afternoon, or good evening, wherever you are. So we're so happy to have you here again on the third and the last day of the conference. So today I have the privilege of doing the opening remarks and introducing our final keynote speaker. My name is Özlem Ergun. I'm a professor of mechanical and industrial engineering at Northeastern University. However, I have spent more than a decade at Georgia Tech with Pınar Keskin-Ocak and Julie Swan, and who are also the co-organizers of the conference. And there we co-founded the Center for Health and Humanitarian Systems around, I think, in 2007. And we have really started to do humanitarian and global health-related work probably in the early 2005 and so on. So we have been active in this. Given that everybody is giving the history, I decided I will say a little bit of the personal history as well. So we have been doing humanitarian logistics, humanitarian systems related work, and have had the privilege to work with many organizations, governmental, humanitarian, and private organizations who are also doing work in the humanitarian sector over the last 15 years. So we're very happy to be here today. I think we had an amazing day one and day two. So what I will do today is I'll tell you a little bit of what I have gotten out of day two, and then I will actually ask you to tell me a little bit about what you have gotten out of day one and two in the conference before we actually start our keynote at 10:15 Eastern time. So before we start, okay, so let's look at the poll first. We have looked at how many people have we all met virtually during the conference. So we see that amazingly, at least one person have met more than 20 people virtually, but we see that a lot of people have met between 5 and 10, less than 5, and then some are questioning whether they even know themselves or not, which probably is virtually true for most of us, in part at least. But before we start, we would like to thank our sponsors, as UPS has been supporting the conference since its initial run in Atlanta. So thank you, UPS. And Chemonix is a silver sponsor this year. Thank you. So as I said, I would like to talk a little bit about my takeaways from day two. And I do these takeaways and closing remarks, it seems like, whenever I'm at the conference, and I see that they're not so different from year to year, that we're all dealing with, in humanitarian context, we're all dealing with very complex problems with many, many interacting challenges. So I had the privilege of listening to the keynote, and then I ended up going to a workshop on drug shortages. And one of the big things that we talked about yesterday was how we sometimes don't even know the root cause of some of the problems that we experience in operations and kind of outcomes. And part of the reason is because the problems the problems are arising because of many interacting challenges, including, as was described very nicely by our keynote speaker yesterday, including infrastructure challenges into access and security, challenges in different standards by different countries and different regions, and sometimes the lack of trained staff who could actually administer medicine or or help with delivering the services. Next slide, please. Next click, please. And what we have heard yesterday over and over is what works or what is needed is really coming to a common understanding. So our keynote speaker had said that at ICRC, they often have to negotiate with groups with radical reviews that we use at time, but unless they do the negotiation, they cannot actually get the access. We talked about standardization, And again, standardization at a global or even regional level needs negotiation and coming to a common understanding. And then we also talked about the global rather than the strictly local perspective, in the sense that especially in the COVID, what became exasperated was governments or regions actually shutting down, such as their exports, in trying to protect or keep some of the supplies, such as PPEs, in country, which actually created problems down the line, even for the same country. So we really have to think about global rather than the local perspective, and sometimes not about the very short, but the long run. And then, of course, collaborate, coordinate, and share information seems to be the key in overcoming or kind of reaching what works. And when we say collaborate, coordinate, and share information, this includes humanitarian organizations, private sector, and the governments. And one thing that I would like to say, and I've heard this both in workshops, the panel, and as well as with our keynote speaker yesterday. I mean, obviously, COVID has impacted everyone around the globe, and we understand that. But we can also see COVID as an enabler, because it's forcing many organizations to activate and to motivate many organizations for doing things differently. Within the United States, at least, I have seen collaborations, at least in terms of distributing and allocation medical products and drugs, these collaborations and information exchanges have never existed, and we thought they would never exist before COVID. But now it's happening because it was necessary, and we're all hoping that now that we have seen that we can do the collaboration and coordination and information sharing because of COVID, maybe we can do it in the long run to create solutions that are more permanent. Thank you. So now I would say maybe we have one or two, we have a little bit of time to hear from you in terms of what did you hear. So what I would, given the time, I'm just going to say that I would encourage everyone to think about what we have all taken away, and also what my colleague Julie Swan always says in every one of our conferences, in terms of let's think about what we take away, but also what's the one thing or the two things that we would want to change and do differently because of what we have learned and what we have seen at the conference. I think that's really, we have a call for action for doing things differently and making a change. Okay, so I'm just going to ask the participants one more time. Is there anyone who would like to share a takeaway or two from day one or day two? Okay, Vanessa, go ahead.
One thing that I took away from this conference is that the emergence of the pandemic has caused there to be a search for agile supply chain, agile and flexible supply chain. So if we're working in the supply chain sector, what we should look out for is to try and improve our processes and make it as flexible as we can.
Thank you, Vanessa. So agility in supply chains. Exactly. All right. Anyone else?
Good morning. I'm also on the East Coast. So I think I took away that so many of our objectives need to be met in tension with another objective. So if we're looking for standardization, we also need to consider using what is available locally and being a bit flexible about standardization in order not to wipe out a local market, and vice versa. Just the theory of tension kept coming up in all the sessions I was in.
I think it's a wonderful point. So really the fact that it's a system that it's an interacting system, and there are a lot of trade-offs or tensions that we have to think about. And fixing one thing might actually impact something else that's very important, that's in a negative way.
Exactly.
Mm-hmm. Thank you. So today we have the honor of having Ms. Anuradha Gupta, who is the Deputy Chief Executive Officer of Gavi, the Vaccine Alliance. So Ms. Gupta has joined Gavi in 2015 And since she has joined Gavi, she put an effort in bringing equity and gender to the center of Gavi's programmatic planning. She's also been driving the efforts to create a model where the countries actually take ownership and leadership of Gavi-supported programs. Before joining Gavi, Ms. Gupta served as the mission director of the National Health Mission of India, which, as you can imagine, is the largest and possibly the most complex public health program in the world.
So thank you very much, and good morning, good afternoon, depending on where you are joining from. So I had an opportunity to hear the two questions that were raised by participants, and the tension that you just spoke about, right? That seems kept coming through the conversations that you had during the last 2 days. Global versus local, standardized versus contextualized, and also the whole value of agility. And let me now try and draw on our experiences at Gavi, coming out of our work with regard to equity and in fragile settings in particular, because you would see, some of that tension actually replayed here. So as many of you might be aware, that Gavi is actually a global vaccine alliance. We are a very unique public-private sector partnership, and we were set up in 2000, in order to save lives of children in poor countries. So equity was really the driving force behind Gavi. And as we started to introduce and scale up vaccines in poor countries, where a lot of children were dying unnecessarily because of vaccine preventable diseases, we started to see the impact that both scale and speed can create in some of the most impoverished settings in the world. And here on this graph, you can see that globally, overall child mortality rates have declined by 44% in 70 Gavi-supported countries. But really, if you look at child deaths because of vaccine preventable diseases, there is a whooping decline of 71%. So an amazing achievement. And this is also borne by the fact that in the last about 19 years, we have been able to support countries in immunizing more than 800 million additional children, which has really saved 14 million lives. And it is not just that we are supporting countries in reaching more and more children every year, but actually children are benefiting from protection of more and more vaccines against more and more diseases. What is very relevant for this audience is to know that immunization now, as a result of the whole model that Gavi encouraged, is reaching many, many more households. So you look at the coverage rates of a lot of essential health interventions, and you would see that immunization is really riding much higher than any other essential health intervention, be it family planning or reproductive health services, or HIV treatment, TB treatment, or bed nets. But what is even more important is that immunization is also the most equitable intervention. And you can see here that the coverage in the poorest segments of population is the highest when it comes to immunization as a health service. And if you have read the book by the Nobel Prize winners for economics last year, Esther and Abhijit, actually they have described immunization as a ladder, that can help the poorest households leap out of the vicious cycle of poverty. And therefore you can visualize and understand the impact of immunization particularly in humanitarian and fragile settings. Now, among the 70 countries that Gavi supports, we of course have 18 fragile countries. So we have our own definition of fragility. We look at the international list, and then we sort of, come up with our own list of countries that are fragile. And currently 18 out of 70 countries in our portfolio qualify to be fragile countries. And a lot of them, as you would imagine, have humanitarian crises. So when we look at the overall progress in Gavi countries, that has been quite impressive. Here you see 81% coverage rate of basic immunization, but in fragile countries, you can immediately see that there is complete stagnation. In fact, since 2009, the coverage rates are up and down, and there are high fertility rates in fragile countries. So every year, the size of the cohort or the population that we have to vaccinate is going up. And a lot of these countries, therefore, struggle to actually stay ahead of the population growth, so are barely able to maintain their coverage. So look at the differential between overall coverage for Gavi countries and immunization coverage for 18 fragile countries. And these countries account for just 23% of a total birth cohort, but they account for 37% of child mortality rates, but also 51% of our zero-dose children live in these 18 fragile countries, with only 23% of share in the overall child population. And what do I mean by zero-dose child? So zero-dose child is for us a marker of acute inequity and poverty. And I'm sure all of you are familiar with the SDGs and really the signature vision of SDG to leave no one behind. And this is our no one in that leaving no one behind vision. So zero-dose child is that child who does not receive even a single dose of the most basic vaccine. And our interpretation and definition of this child is that this child is a North Star to those communities that are missing many other essential services, because typically immunization is the easiest and the simplest and the fastest service to deliver. And the fact that you have children who are not receiving even a single dose of the most basic vaccines is a kind of an alarm bell which takes you to those communities where women are not receiving even the most essential services, girls are not in school, they are getting married early, they are producing children every year because they don't have access to contraception, sanitation, nutrition, hygiene are lacking. And you can see here a very strong connection with acute and extreme poverty. And our analysis shows that 2 out of these 3 zero-dose children actually live in households that subsist on less than $1.90 a day. So really poor populations that suffer from multiple deprivations and compounded vulnerabilities. And reaching these children is something that we have set as a central goal to reach in the next 5 years. So leaving no one behind is a vision that has become extremely concrete for Gavi, because we have committed ourselves to really reaching these 11 million children in Gavi supported countries who are zero dose. And I just explained to you what is a definition of zero dose. Now, there is a very startling fact here that you might notice, and that is that 50% of children who are dying of vaccine preventable diseases in Gavi countries actually are zero dose. And why is this a very alarming figure? Because it is only 1 in 8 children who is zero dose. So I showed you the coverage rates, they're 81%, right? So 1 in 8 children is zero dose, and yet these zero dose children suffer from a disproportionate amount of deaths, 50% of overall deaths. So you can see that there are these communities which are having to bear a disproportionate burden of disease, death, disability, catastrophic medical expenditures, which then further pushes them into deeper poverty. Here you can also see that, you know, a lot of these children have mothers who are deprived of essential services. So a lot of women here in these communities are deprived of antenatal care. They do not have access to skilled birth attendants. The households do not have access to water and cleansing agents. And as you know, all this has huge gender ramifications and implications. So really a very powerful analysis to show that communities which are highly vulnerable, very poor, stigmatized, suffer from not just one vulnerability or one deprivation, but a plethora of deprivation requiring really multi-sectoral collaboration at the global level, but more importantly at the country level. You, I'm sure, have been talking a lot about COVID-19, and we all know that COVID-19 has already exacerbated inequities. So many more people, millions actually of people are being pushed into deeper poverty, and there are women who are falling off the ambit of services. There is an increase in the incidence of domestic violence, and really communities living on the margin, sort of having their deprivations even deepened. And we therefore expect that the number of zero-dose children in Gavi countries, particularly in fragile settings, is going to go up. There are new interagency child mortality estimates that have just been released, which are showing that if disruption of health services is not immediately contained and health services are not up and running, then the indirect impact of COVID-19 could mean 1 million more child deaths within a span of just 6 months. So really a wake-up call for all of us. And I also want to highlight that when children miss their timely vaccination, then they also are at heightened risk of disease and disease outbreaks, because you have these communities where services are not reaching. So you have clusters of unvaccinated children, and therefore the disease spreads there like wild fire. And 80 million children we anticipate, are already out of the ambit of services, and more than 130 million children actually who should have been reached through different campaigns that Gavi supports have not been reached because of the widespread disruption that we see in our countries. Now, really turning my attention to fragile countries, I would want to just highlight the importance of differentiated focus. So you guys, discuss this, the local and the global, but what I would want to emphasize also is the importance of very differentiated strategies, for different countries. So when we look at our 18 fragile countries, we can immediately see that 5 fragile countries account for 42% of our zero-dose children. But if you were to further unpack this data, you would see that Nigeria alone accounts for 23% of these children, followed by DRC with 10%. But there are also countries like Chad, which has a smaller number of children who are zero-dose, 0.2 million, but the challenges there are extremely deep. And the same is the case in Somalia and Afghanistan. So the strategies that are going to work in Chad may not necessarily be the strategies that are going to be fruitful in Nigeria. And I think it was last year that I had gone to Chad, and when I met with the president of Chad, he said to me, look, the global institutions unfortunately do not understand the value of contextualized strategies. They all come with a standard approach, one size fit all notion. And in case of Chad, what he suggested was that in one province where actually communities care about their livestock and they are nomadic populations in a province called Batha, he said that it would be much more beneficial if livestock immunization and child immunization could be brought together, because when people care for their livestock, that is the best time to remind them of the value of immunization of children as well. So really a very compelling example of a highly contextualized and differentiated strategy. Another thing that we have grown to appreciate a lot at Gavi is the value of flexible policies and nimble processes. You know, in fragile settings and humanitarian crises, agility, as some of you said, is so important. So really the swiftness of response is critical. We can't be navel gazing, working through our complex processes to rush support in humanitarian settings. Therefore, we have come up with a set of highly flexible policies and very nimble processes. For example, in case of fragility, emergencies, and refugees, we straight away provide much more health system strengthening support, much more intensive technical support, more vaccine support, a lot of flexibility around programmatic approaches, because normally we focus on immunization of children up to 1 year, but in case of refugee camps, sometimes we have to vaccinate children up to 5 years or 10 years because you want to prevent disease outbreaks, and those are children who have not received their vaccination in time. So a lot of flexibility, and I think that's an important thing to keep in mind. We are now very focused, as I said, on zero-dose children, and we think that there has to be a very systematic approach, which we are now trying to socialize all across the alliance and in countries, because the first step we realized in this journey is to really identify where our missed populations are, or our zero-dose children are. A lot of times, these children are invisible, right? Because they are not on political radar, they are not influential, the voice of these communities is not strong. So really shining light on where these zero-dose and missed communities are is the first vital step. And it is not easy. It is easier said than done. And we are now promoting a lot of innovations to see how we triangulate data sources, do geospatial mapping, integrate our digital strategies to really identify not just the populations who are missing out on services, but also the barriers that impede them. For example, a simple thing like, you go to a poor urban slum in Kenya, and what we found was that women are working during the daytime and they have no time to bring their children for immunization session, and they are not in a position to forego their daily wage. So just changing the time of immunization to late evening or over the weekends actually help those women bring their children for immunization services. So reaching, where you talked about agility, we are emphasizing a lot of flexible, agile approaches, which actually focus both on community trust, and that public trust in public health services really is emerging as a major barrier today. And I think that applies to humanitarian settings where there is a lot of deficit of trust between the governments and populations, and therefore populations push back on services even when they are taken to them. So really focusing on both demand and supply side intervention to enhance demand and public trust is a very important aspect of our strategy. And then monitoring and measure. How do we monitor? Unless these populations are identified, reached, and constantly monitored, because even if you, sometimes health-seeking behavior is very weak. They are on a move, right? They are mobile, they are nomadics. And then how do you make sure that you continue to monitor, the uptake of services, and make sure you can go back to those communities so that they can avail themselves of the full range of services and measurement of results, so that we can learn from what is working, not working. This is something of immense value to us. because we can do interventions, but unless we monitor and we measure, we don't know where to course correct. And of course, advocacy is always such an important piece of anybody's work. But what we have realized at Gavi is that if we use more and more data and evidence, then that's something that makes your case very compelling. And with a lot of heads of states, when we plead for greater political attention, sometimes we see them saying, look, but we already have 100% immunization rates. And then you have to actually pull out credible data to show that that's not indeed the case, and why, there are different data sources that are showing that communities are missing out on life-saving interventions. I would also sort of want to say that within countries, you need to go subnational, and really understand where exactly are inequities and how do you approach them. So, for example, when we started to work in DRC, we realized that, within DRC, there are lots and lots of disparities and inequities. And therefore, we worked with the government to put together a plan which they call Mashako plan, which is focused on 9 provinces, which target high-risk areas, high-risk populations, and then localized tools in order to really sort of make sure there are no stockouts, that there is community outreach, and that not only are services delivered in a reliable manner, but there is also uptake of those services. So I really want to emphasize the critical importance of looking at subnational data and go subnational in terms of focus. And here you can see that as a result of all this effort, we are now able to track as to how many children are reached and how many children continue to be missed in individual provinces of DRC. And this kind of monitoring, encourages program managers and health workers, and they want to do better and better because there is real-time data that is coming to them. Now, community ownership is also something that I would want to highlight. Like in Mali, we see a very exceptional situation. Mali is, conflict-ridden. There's a lot of political instability, and yet the coverage rates in Mali are extremely impressive. And when we try to understand why so, we knew that it is community ownership, of their primary health services, which actually enhances public trust in services and also the uptake. In fact, when we started to design a new plan with community, we saw that community started to implement some of the new interventions that we had agreed on ahead of our funding. So before our funding started to flow, we started to see some very, very good sort of interventions. And I think that this is something that is extremely critical, bringing communities to the heart of programming. And really, multi-sectoral collaboration and purposeful partnerships is another thing. That is one of the most powerful learnings we have had. So we really struggled in fragile settings, as I told you. Our coverage is plateaued. We haven't been able to break that jinx. And all this work is very new for us. And one of the things that we realized was that the kind of partners that we have to work with in humanitarian settings are going to look very different. And, so during the last about 2-3 years, we have tried to broaden our partnerships with non-traditional sort of actors. And this includes faith-based organizations, CSOs, and humanitarian organizations. And then making sure that when we reach communities, then we reach communities with a holistic package of services, because these are such difficult settings that you can't continue to give them a health offering or an intervention one by one. So when you are able to reach these communities, try and enrich that offering so that it's not just immunization, it is also nutrition, it is antenatal care, it is deworming, it is growth monitoring, and it's a whole array of services. And then, of course, the last point that I want to make is that there is room for context-specific innovations, and that can really help some of these fragile countries facing humanitarian crisis leapfrog. A lot of times, we think it is about fundamentals, because fundamentals definitely are weak and broken in these countries. But I would really want to emphasize the importance of focusing on fundamentals, but also not ruling out the value of context-specific innovations. And we are seeing that in our work with a lot of fragile countries. And here I just want to share with you one example of Afghanistan, where actually we brought a new partner, to help the country management to monitor the program. We invested in new tools which are very local, but which are digital and very smart. And that has really helped the local managers and the health workforce to continue to monitor the work that they are doing. And these simple innovations are telling us that the dividends and gains can be very big. And we have just now put together an innovation catalog so that we can create a menu of innovations for countries and then leave it to them to choose, because we don't want to impose anything on countries from global level, but we definitely want to stimulate thinking at the country level about some of the innovations that have proven to be successful across other countries. So really, I would want to end my intervention by emphasizing that we recognize that bridging the humanitarian health and development nexus is key to leaving no one behind, which is SDG's vision, but it is also at the heart of Gavi's vision. And I'm sure all of you are working in organizations that have embraced a similar vision. So thank you.
Thank you, Ms. Gupta, for a wonderful speech. So I would like to now open up the floor for question and answer. As we have done in the past days, if you type your questions in the Q&A section of the Zoom, I will go through them and either read the questions for Ms. Gupta to answer or ask you to speak up. I might invite you, if we have time, to actually ask your questions live. So I will actually, as we're waiting for more Q&As, questions to come in, maybe I'll ask my colleague Julie Swan to come up live and actually ask one of her questions. She's typed 3 of them. So I'll ask her to just come up live and ask one of the questions, Julie, if you will.
Yeah, thank you so much, Ms. Gupta. There were so many interesting things. That's why I had so many questions. One of the questions that I have is, I'm sorry, there's a little noise here. One of the questions that I have relates to whether, sorry, I'm trying to get to where I wrote it. I don't see it right here. One of the questions relates to COVID-19 vaccine, and some of the vaccines require an ultra-low cold chain. And can you talk a little bit about what Gavi and countries and partners might be doing to prepare for that, or are you planning for some of the other vaccines? Thank you.
So COVID-19 vaccines is something that we are very actively engaging on, actually leading on, as you know. And what is different about COVID-19 vaccines is that Gavi is leading on making sure that there is equitable global access. So we have set up a facility, where we have rich countries and poor countries that we traditionally support coming together, right? Because we didn't want this nationalism to sort of lead to a situation where rich countries corner all the vaccines and with poor countries left behind, right? So that is why it's a sort of a mechanism that has been created, and we are succeeding with that. Now, the thing here is that so far as ultra cold chain is concerned, so that there are all kinds of vaccine candidates now, right? And we have a big choice. So at this point of time, about 9 vaccines are in third phase trials. All of them do not require ultra cold chain, right? And we know that, so there are 2 categories. One is the rich countries, or countries that actually can are paying for the vaccine themselves. But there are 92 countries that we are supporting. And we are going to procure the vaccine and give it to them because we know that the economies are in a shambles, right? So we traditionally supported 70, but we have brought in more countries now, middle income countries. So there, what we feel is that ultra cold chain is going to be very, very challenging, to organize. So time is of the essence here. So we are trying to actually procure vaccine candidates for those such vaccine candidates for those countries that are suited to their local context and that are easy for those countries to deliver. And of course, ultra cold chain might be required in the case of very few vaccine candidates, and therefore what we would do is actually take them to those countries where already those capacities exist. For example, for Ebola vaccine, that also where we played a big role, ultra cold chain is required. So in DRC, in Uganda, in a few neighboring countries, we already have ultra cold chain, because that was required for Ebola, and we are going to build on that and make sure that we utilize that capacity for any vaccine candidate that may require ultra cold chain. But really, as a more general policy, we would want to encourage countries to sort of look at different options. One is sometimes animal husbandry or livestock sector has ultra cold chain, right? Or sometimes ultra cold chain can be also hired, right? So if countries have that capacity, then we would match the vaccine that we provide to countries with those kind of capacities. But if the country doesn't have any kind of option on ultra cold chain, then we have other vaccines that would not require ultra cold chain. Sorry for a long answer.
No, thank you very much.
Thanks a lot for this wonderful presentation. I personally really enjoyed it. So my question was that everybody actually talks about partnership, coordination, especially in the field. This is important given that all these organizations have limited resources. But I wonder, what are the main barriers that would you highlight that doesn't let these organizations coordinate in the field? Thank you so much.
Yeah, so I think this is an excellent question and not an easy one to respond to. But as I see it, right, I think it is really the way the incentives are designed. So, when the support is flowing from global levels, there is a lot of focus on, report to us, what is it that you have contributed, right? So this attribution versus contribution lens. So everybody wants to do their own stuff. They have funding for a very narrow piece of work and they want to deliver on that and they want to report back. And I think there is no pressure, neither pressure nor incentive to actually look more horizontally, for collaboration at the community level. And I'll just share one example with you. When I went to Cox's Bazar, right, in Bangladesh, and this was about a year ago, and just before COVID-19 struck actually, and I was very taken aback by the fact that, for example, we were giving a lot of money for immunization related stuff, including cholera campaigns, and things like that, because there is a lot of cholera there, and apart from other vaccine preventable diseases. But there was no pressure on implementing partners to actually collaborate, say, with sort of UNSCR or World Food Program. And so those communities need nutrition. So there are big WFP centers there which are distributing nutrition, but nobody actually explored the potential of juxtaposing the immunization service points with nutrition distribution centers, right? So this was, and so because, everybody is getting their funding and there is so now therefore we, at least from Gavi's side, we are constantly saying, please tell us, how are you going to integrate? How are you going to, so just generating that pressure and also stimulating that whole thinking about how to collaborate, I think will be a good way forward. For the first time, I've been working in health space for a long time. For the first time, I see real traction behind for this, right? And a real global push to say, look, guys, you have to look at primary healthcare as a whole. You have to look at health enhancing interventions. Nutrition is not typically regarded as a health intervention, right? But, it is, or sanitation or water. So how do you bring this all together? So it's challenging, but I think we have to continue to push and redesign and review our incentives and monitoring mechanisms to actually put a lot of premium on integration and collaboration.
Thank you. So we'll now ask Claire to speak up actually and ask her question. And then after that, I think I'm going to just read some of the other questions, just given that we have...
Hi, first of all, thank you so much for your wonderful presentation. My question is, in your opinion, what in the last 10 years has been the most significant innovation in immunization care and programming? And how is that innovation felt by the zero-dose child?
Yeah, so I think this is you can look at innovations in a variety of ways, right? So first of all, the global level innovation. So I would talk about that. For example, to me, the most compelling example of global innovation is the innovative financing mechanism that we set up. You know, I don't know whether you have heard about IFFIM. So we were a pioneer in setting that up, and we floated vaccine bonds and actually raised $6.5 billion. You know, so the donors made long-term pledges, 15 to 20 years, and riding on that, we just leveraged capital markets through vaccine bonds. And that $6.5 billion meant that we didn't have to wait for hard cash to come in, right? And that is what I think lent Gavi the ability to fast forward impact, you know, do large scale programming in countries, and it's our ability to do things at scale, as I said, and at pace, you know, that has given us these wonderful results. So this is an example of, you know, the upstream global level sort of innovation. Another this thing that I think has really helped a lot is, for example, the whole innovation around the auto-disabled syringes, right? So auto-disabled syringes, this is injection safety. Immunization is the only program in poor countries which actually uses auto-disabled syringes, right? And we procure that in bulk, and we give it along with the vaccine to countries. So even in a country like India, you know, it is outside immunization, auto-disabled syringes are not used. And as a result of that, you see a lot of public health issues, including hepatitis C, right? Where rates are, because unsafe injection practices can lead to a lot of public health issues. So that is another innovation. A third innovation is vaccine vial monitoring, right? Where we every vaccine has that monitor. So if it is overheated, then the color changes, and the health worker knows that it has to be discarded because the vaccine has lost its potency. So these are three upstream innovations, product innovations and financing. But one great example that I can share at the country level really is the temperature monitoring that we do, right? So where we have invested a lot in LMIS, the logistic management information systems, and also including temperature monitoring. And that is actually enabling the countries to follow their stocks and actually understand where stockouts are, or where a cold chain is not functioning, or whether there are temperature excursions. So that is helping countries to take their vaccines really to the last mile, making sure they remain potent. And the cold chain has become now solar driven, and that's another innovation that has reduced dependency on electricity and power, and has helped countries and the alliance actually to take the next generation cold chain into those communities which would have never gotten cold chain, which are so essential to taking vaccines.
Thank you. So I've been monitoring the questions, and I'm going to combine a few of them together. So there are a few questions around the role of the community health workers in increasing vaccine coverage. And particularly also there's a follow-up question around often the community health workers need only simple and robust technology support to improve their effectiveness. So what is Gavi planning to do, or what is Gavi doing in this space?
Yeah, so we are doing a lot of work now in this space. So first of all is just the capacity building through digital tools. And, that for years, billions and billions of dollars, for decades actually, billions and billions of dollars have been invested in traditional ways of capacity building. And, that has a lot of disadvantages, because you are actually plucking scarce health workforce from their facilities and their positions, and then getting them into, that cascading model of sort of training. So what we did was to actually work on very interactive digital capacity building tools. And COVID-19 has actually provided us an opportunity to scale them up. And it is amazing to see how many countries have rapidly scaled up digital modules to do capacity building, capacity enhancement or skill enhancement during COVID-19 with great outcomes. So that is one. The second thing that we now in COVID-19, we are pushing for, personal protective equipment, but Gavi was the first one to raise this issue of gender dimension of PPE, because in the beginning, for example, PPE was designed for men. It was very bulky, and it wasn't just the right thing for women. They found it oversized and bulky. So with UNICEF, we have worked a lot on making sure that just the PPE that they have actually is is suited. Then, also enhancing awareness about security issues. When humanitarian crises and difficult settings, we have a lot of female, as you know, health workforce, right? So how do we make sure that greater attention is paid to their sort of security issues? And lastly, I would say tools like vaccine carriers. So we have invested a lot in making sure that vaccine carriers become lighter, so that if women have to carry them, they can carry with ease, right? So there's a lot of innovation going on there. And on data, we are doing a lot of stuff where we are saying, okay, if they don't have to do all those bulky sort of health registers, but they can scan documents, and then this goes to a central server where it is automatically collated. And there are some very fantastic examples of that as well. So we ran very quickly analysis, right? Very quickly, and we through that analysis, and we use a lot of institutions like London School of Hygiene and Tropical Medicines and several other. So it's a collaborative, and then they established the fact that if we maintain routine immunization services, then for the risk of one COVID-related death, you are actually saving the lives of more than 100 children. So, and therefore our message was very loud and clear that routine immunization services have to be sustained, because if you don't sustain them for fear of transmission of COVID-19, you are actually putting the lives of 100 children at risk for just one likely COVID related death. And then the second step was to immediately support countries in following the safety protocol measures that are needed. And we reprogrammed our support very nimbly in a very agile manner to help countries do that, adapt to the new protocols so that they can continue to deliver services.
Okay, thank you very much. We still have quite a few questions. What I'm going to do is I'm going to post these questions into our Slack channel for creating further discussion, but we would like to thank you again. I'm just clapping for everyone.